Yes, sir. Please start.
So good afternoon, everybody. On a Saturday, I welcome you all to this special program. A very important program that Johnson & Johnson has put up with, known as the Tech Talk, and it's a 7-part series of a Phaco masterclass. And this is the first step was done about a week back, where the machine parameters and everything about the machine was discussed by our star speaker, that is Dr. Mohan Rajan. And today we are going to touch on another important topic, that is the wound construction. And I'd like to introduce our guest speaker, that is Dr. Mohan Rajan. He is the chairman and medical director of Rajan Eye Care Hospital, Chennai, Tamil Nadu. He's also the president-elect of the TNOA and the past president of IRSI and the past secretary of MCOA as well. He has authored 4 books, published 42 publications in peer-reviewed journals. He's chaired several symposia and presented more than 2,000 papers in national and international ophthalmic conferences. He's conducted instruction courses in ASCRS, AO, ESCRS, APO, APACRS, SARC, and presented 20 named orations. He's performed 30 live surgeries in conferences in India and abroad, and has performed about more than 150,000 cataract and 6,000 vitreoretinal surgeries. He has received about 22 awards for the Tamil Nadu government and various other organizations, including ACE Award from the APACRS and the IRSI Gold Medal. Apart from that, what you don't know is he treats a lot of celebrities in Tamil Nadu as well. And the best part about him is he's a fantastic presenter. And what he does the best is he makes learning fun. So I've really loved his videos, and it's a pleasure to have Dr. Mohan Rajan here. Thank you, sir, and over to you.
Can I share my screen?
Yes, sir.
Are you able to see my screen now? Yes, sir.
Yes.
Namaste, good afternoon, good morning to wherever you are. And let me at the outset thank the J&J for this wonderful opportunity. I think this is a very good Phaco Masterclass series. There are 7 modules in this series, and the first module was over 1 week back. Every Saturday, tune in at 3 o'clock from 3 to 4 p.m. for this very interesting webinar as well. And let me also thank my very good friend Karan. Always call him the future of Indian ophthalmology. He's an young ophthalmologist, very dynamic. I'm very happy that Karan is moderating this session. Thanks, Karan, for the wonderful introduction. And over to the talk. I'm going to do that. For the next 30-35 minutes, I'm going to talk to you on the wound construction. Many of us take it very lightly, but the wound is the most important thing as far as the Phaco emulsification is concerned. Whether you want to give good intraoperative or good postoperative results for this patient, the wound is very, very important. Now, what is the location of the wound, the geometry of the wound, the blades and knives which are used for this wound? Why is wound construction important? It plays a major role in preventing endophthalmitis, because a bad wound or a leaking wound can produce endophthalmitis. Please understand. Second only to topical iodine 5%. Many reports suggest that postoperative IOP may fall to less than 5 millimeter of mercury with the wound this thing. Yes? 1 minute, huh? Yeah. Monday. Sorry for that. The importance of a wound construction is very, very important as far as the endophthalmitis is concerned. And as I told you, when the wound starts leaking, the postoperative IOP may fall to less than 5 millimeters of mercury. What are the Phaco wound functions? Access to intraocular structures, allows intraoperative maneuvers, secure closure of the wound postoperatively, increases intraoperative safety. The wound acts like a very good safety valve for you or what we call as the internal corneal valve, is very, very important. Provides the strength and the stability, minimal corneal contour change, conversion to a larger wound, physiology and cosmetic appearance. All these are characteristics or desirables as far as the wound is concerned. Location, tissues which are involved in the wound, the length of the wound, the width of the wound, the configuration of the wound, the anesthesia of the wound. These are the various topics I'm going to consider while considering this wound construction. What are the factors affecting the wound integrity? The size, the location, whether it's scleral, limbal, or corneal, the quality, whether it's a square or a rectangle, not thin flap, not ragged flap, blades, whether it's a metal or a diamond one, wound burns can affect the integrity of the wound, extension for IOL insertion, again, is very, very important. Hydration of the wound is also important at the end of the surgery. Watertight seal is also very important. All these factors help in preventing endophthalmitis. Unfortunately, most of us don't give importance to the wound, but I feel that the most important thing in preventing endophthalmitis, apart from the routine povidone iodine and other factors, is the wound integrity, which is very, very important. The location of the phaco wound can be either temporal, superior, or superiotemporal, or just plain temporal, or it can be superior nasal or nasal. For nasal, it may be a little difficult, but what is important is inferior incisions are also very exceptional. When there is a huge superior bleb, you can go either temporal or inferior as well. Nasal incisions are less effective, and that is the reason temporal incisions are what we always do, are exposed to the atmosphere. We have to be a little careful. So what I do is I go a little superior temporal in both eyes so that it is covered by the lid as well. However, the temporal incisions are associated with the less astigmatism or the least astigmatism, especially when you are confined to a 2.4 millimeter width of the wound. The tissue placement of the phaco wound can be either scleral. The scleral can produce postoperative inflammation, postoperative IOP increase, endothelial cell loss can be more with the corneal. And endophthalmitis, definitely the corneal infections are more possible to do to incidence of endophthalmitis, because the corneal valves or the corneal incisions are not as strong as the scleral incisions. The tissue placement, again, can vary from clear corneal to near corneal incisions. As I told you, clear corneal incisions we don't do unless it's a femto, wherein the clear corneal incision, because it has an offset of about 0.3 or 0.5 millimeter. And that is why the femto incisions are not very, very used by many surgeons, because it's a clear corneal incision. Whereas near corneal incisions or limbal, anterior limbal incisions, which I'm going to talk about as well. So the location can be either clear corneal or anterior limbal vascular arcade. It starts, there can be a mild ooze while starting, and that is an indication that it is starting in the anterior limbal vascular arcade, or it can be limbal, or it can be scleral limbal, or it can be scleral as well. So these are the various positions you can locate the wound, wherein it can be clear corneal or near clear corneal or anterior limbal or posterior limbal or scleral as well, or scleral limbal as well. You can see the clear corneal incisions or anterior limbal. You can see that mild ooze is there. The ooze is very necessary because it aids in the vascularity of the incision. And then you can go up on the cornea. You can make a groove with a crescent knife, and then use the keratome, and then go inside, and you can see here the rocking movements and entering in a plane which is parallel to the surface of the iris and parallel to the endothelium as well. Incisions in the vascular area heals in about 7 days by keratoblast response. Incisions in the avascular area heal in about 60 to 90 days by metaplastic response. So that is the reason why the clear corneal incisions are not as strong as the scleral incisions or the limbal incisions. This you have to keep in mind, and this you have to keep in mind because many of us are using clear corneal incisions. You have to be very, very careful. Incision is the limbal incision is the beginning of the conjunctiva. The tendency to bleed, you can see here, making an incision just in the posterior limbus at the beginning of the conjunctiva, and then going up into the sclera of the cornea. And during phaco, if not done well, the conjunctiva will tend to balloon and something like a chemosis, which can produce very crazy reflexes on the cornea. Scleral limbal incisions, wherein you go a little posterior, very vascular, heals very quickly. The blood products creates a sticky seal in a few minutes, can make a long cord length, can be done even for PMMA IOL or a 5.5 rigid IOL or a 5 millimeter or 5.5 millimeter rigid IOL. These are the scleral tunnels which I used to make for pediatric cataracts, because definitely in pediatric in children, congenital cataracts, the scleral tunnels definitely are safer, much safer than the clear corneal incisions because of the incidence. And always I put a suture, whether it's a scleral incision or a clear corneal incision, a congenital cataract, because it's very important that you avoid, because the children can rub the eye and that can produce a wound leak as well. But scleral incisions are definitely a way to go as far as children are concerned. Whether to groove or not to groove, the early advocates of grooving said it avoids a ragged incision, controlled depth, creates a hinge which flexes, relieves the tension of the flap. The current studies suggest otherwise. It disrupts the epithelial barrier, allows the fluid to go into the wound and retard the pump action, may account for persistent irritation post-operative. Sometimes the patients can complain that there can be a foreign body sensation post-operatively because of the groove. So hinge is not really necessary if you're going to be less than 3 millimeters width of the wound, which is the normal case scenario nowadays in phacos. Whether to use a diamond knife or the metallic, I'll come to it a little later, because the metallic knives are as good. Diamond knife, you can see the OCT images are very, very clear. With the groove, you can see that. There's another OCT image wherein the side port is being also done well. So this is the way it has to be configured, wherein it has to go down and then go up on the cornea, then enter into the anterior chamber, or what we call as typically a triplanar incision. The length of the phaco wound. The length of the phaco wound is a visual axis and the astigmatic neutrality. Please understand this factor, very important. That is, the length of the phaco wound is very, very necessary. You can't afford to have a 2.8 millimeter width of the incision and only 0.5 millimeter length. That is actually a disastrous and produce problem like iris prolapse, wound leaks, endophthalmitis, chronic inflammation, postoperative uveitis. All these problems can occur with this shallow wounds. So length of the wound is very, very important. It depends on the length of the incision, depends on the angle of the incision. To go down,
it should be between 1.5 and 2 millimeters.
1.5 to 2 millimeters is what is necessary.
Also allows good surgical access.
Yes.
The length of the keratome penetrates the cornea.
You can see here how this animation shows you.
The incision ends up too short and it leaks.
If you go straight away like that, that is a bad incision, too short.
Then the incision ends up too long.
So you go up on the cornea,
access, distortion, and wound burn.
And then
for corneal stab incisions,
you should
pass the keratome in the plane of the iris and slightly upwards to get an incision that's the right length.
The angle of the incision is very, very important to get the right length. Again, the length of the wound, as I told you, the visual axis, the astigmatic neutrality is also there. This is a 2.8 millimeter incision. You can see the side port is about 1.1 millimeter with a length of about 1 to 1.25 millimeter. And this I do a 300 micron guard knife and then go up on the cornea and then dip down and enter in the anterior chamber. You can see the length of the wound is almost 1.5 to 2 millimeter, which is very, very important. There's another patient with a 1.8 millimeter wound. You can see here I'm making a groove there. This is a guarded knife, and this is a diamond knife, which is 1.8 millimeter. The advantage of a smaller incision is that the 1.8, you can have a length of about 1.5 millimeter, which makes the incision almost a square shaped incision, which is very, very important for you. I'll come to it a little later. The width of the Phaco wound, the instrumentation, and the safety of the incision is also very important. What is the incision funnel? The corneal sections up to 3.2 millimeter. More than 3.2 millimeter, you have to go scleral and use a front incision if you're going to have more than 3.2, because it can produce significant effect on the astigmatism. If you're going to stick to corneal incisions, stick on to 2.8 or 3 or 3.2 millimeter, or even less than that. Nowadays, we are using only 2.2 or 2.4 millimeter, through which we are able to put a lens as well. Just to make sure the side port is also very important as the main port. The side port also should be mini self-sealing. Always make the incision in the tight globe. Inject viscoelastic. This is a mature cataract. I've injected trypan blue. I put a 300 micron guard knife. And you can see here, this is a metal knife with a bevel up. And you can see here how I'm entering the cornea, entering the anterior chamber, creating the internal valve. The width of the wound is also important. As I told you, if it's going to be scleral, go within the scleral incision. That is the incisional funnel, which will make that astigmatic neutral or produce very minimal effect on the astigmatism. What is the anesthesia? Topical anesthesia for all clear corneal, near corneal incisions. Subconjunctival, more comfortable for scleral incisions. Infiltration anesthesia for conversion into a larger wound, either a subtenon's anesthesia or a parabulbar anesthesia. Sometimes you may have to use even a peribulbar anesthesia. Square or no, near square is probably the best. It can be either one step or a two step or a three step. Normally I do a two step. I make a groove, a small groove with a 300 micron guard knife. Know exactly where you start from, and then go up on the cornea and enter into the anterior chamber. You can do a three step also, wherein you can do a groove and then make a tunnel with a crescent knife, as I showed in the earlier video. End of the day, the most important thing is the arc length must be bigger than the chord length. So this is very, very important for you to understand this ball game. Making a square incision is very, very important. Almost a square. Very difficult to make a very square, absolutely a square. You can't have a 2.8 millimeter with a 2.8 millimeter length of the incision, because it will be too long into the cornea and obscure the view during the phacoemulsification. You can have a 2.8 with a 2.2 millimeter length of the wound, which is good enough, which is almost like a square incision. Why do you need a square incision? A square incision resists an opening pressure of 525 pounds per square inch. Then even if you put a boulder on the incision, the wound will not open. Whether it is a 3 by 3 millimeter or a 2 by 2 millimeter, which is a square incision. A wound of 3.2 by 2 leaks even with a very, very minimal pressure, especially with the IOP is low. So if there can be a wound leak and the IOP becoming low, further leak can occur and ingress of fluid from the conjunctival sac into the anterior chamber, producing endophthalmitis. And this, I feel, is one of the most common reasons for the endophthalmitis in the current scenario. If the size is more, increased to about 3.2 into 2.5, the resistance to leak increases 8-fold, which means it is very, very important for you to understand this very importantly, because a square incision or almost a square incision is very important. That is, if you're going to have a 1.8 or a 2.2 millimeter, you can go 1.5, 1.75 millimeter into the cornea. If you're going to have 2.8 millimeter length, that is width of the wound, you can go 2.2 or 2.25 millimeter into the cornea. Incisions in IFIS syndrome, intraoperative floppy iris syndrome, anterior incisions, longer incision, low threshold to suture, calibrated side port incisions, like what has been described by Rohit and Tushya Om Prakash from Amritsar. Well-constructed corneal incisions, both the main port and the side port, the long tunnel. You can see here the anterior incision is very, very important. In all patients, more importantly, when you are expecting IFIS, when the patient is on tamsulosin, you can see here the anterior incisions, making a longer incision is very, very important. Again, you can see here, even the side port incisions, you can have calibration, or you can make sure the side port incisions are also very long in this. Or you can use well-constructed femto triplanar incisions. Because I got access to catalysts, about 50 to 60% of the cases, I use the incisions. If the arcus senilis is not very dense, and then I will use the main incisions. I use the main incisions to some extent the side port incisions as well. And another important thing is the advantage of the triplanar, the femto, the catalyst incisions is that it can be a triplanar incision. You can see here how the incisions are being created, both the main port as well as the side port, whatever the size you want, whatever length you want. You can have a length of about 2.8 to 2.5 millimeter or 2.25 millimeter or a 2.2 with the 2 millimeter, which is almost like a square incision. So this is the advantage, but more importantly, the triplanar incision makes it even more safer. Especially when I am considering an IFIS patient, I don't want the iris to come out through the incision. So I create a triplanar incision, and especially when I'm using, you can see here in this patient, I created both the main port as well as the side port incision, and how easily it is opening up as well. So the femto incisions are also very, very important. The configuration of the phaco wound is next I'm going to discuss. The more importantly thing is to create a linear inner corneal valve. The inner corneal valve is one of the most important thing. How do you create a linear inner corneal valve? You have to go up on the cornea and then dip down into the anterior chamber. That is dip down. When you dip down, you can see wrinkles on the cornea as well, and then enter into the anterior chamber in a plane which is parallel to the surface of the iris and the lens, and parallel to the, you don't want to touch the endothelium, you don't want to touch the lens capsule as well. So these are the very important thing. The configuration of the phaco wound, wherein you go vertically down and then vertically, then up on the cornea and enter into the anterior chamber. In essence, you create a triplanar incision in these cases. So as I told you, the configuration, only if clearly the incision is more than 3 to 4 millimeter, then I would suggest they go the incision within the incision funnel, create a frown incision. Look at this, what is called the concept of Langermann's hinge, which increases safety and also produces lesser astigmatism. Just to show you how the frown incision is made in an SICS, I made with a 15 blade, and then I'm going with a crescent knife.
The capsule.
I'm making sure
chamber is
that the inner
keratome and is
extended inside a little more than the outside. So this is a frown incision for an SICS, and the same principle can be also be done if you're going to have a larger incision for phacoemulsification, especially when you're doing the rigid IOLs. Does the size matter? Remember, when you go smaller, instrumentation becomes even more important. The wound is tight, more prone for heat, more prone for corneal burns. Stretching such a wound to put an IOL cause an unstable wound. So many of us put 1.8 millimeter and try to put what is called wound docking, dock the lens and try to inject a lens to the 1.8 millimeter. You actually cause more of a stretch of a wound. So what I would suggest is I'm doing now only 2.2 or 2.4 millimeter, wherein the cartridge goes inside very nicely. Whenever you do the wound assisted or the wound docking, there is a stretching of the wound. When you stretch the wound, the stromal fibers get disintegrated and cause an unstable wound as well. Better to neatly cut it slightly bigger and pass the viscing to make the wound. Again, whether the diamond and stainless steel keratomes, whichever to use, watertight construction is important. Limit the corneal incision to less than 3.2 millimeter, not 3.5, 3.2 millimeter. That is my take-home message. Diamonds are forever. Diamonds are cost effective. They are very good. They can be used. I was using diamond knives. Even now I'm using diamond knives regularly. But nowadays the metal knives are also come out with excellent quality as well. Only thing is you should know when to stop using them, in the sense that use it for only one case or two cases. Sometimes these are all disposable ones, so that you don't have a blunt edge. A blunt edge can produce a Descemet's problem, a problem in the Descemet's, a sudden entry into the anterior chamber. It can produce a rupture of the anterior capsule as well. So diamonds are definitely very smooth, very quick. The edges are very perfect. The problem is sometimes it can cut through just like a cheese or the butter. But more importantly, it's because there is no resistance on the cornea, and you have to have a learning curve for these diamonds. The steel keratomes of quality is getting better and better. There are many companies which are doing this. Just to show you how I'm creating a crescent knife. I'm creating a tunnel starting from the anterior limbus and going up on the cornea and then dipping down. When I dip down, you can see the dimple on the cornea, the wrinkles on the cornea, and then dip down, and the steel gives you the feel of making a tunnel because the resistance in the corneal tissue is there. The diamond, you don't have resistance. So many times when you use the diamond, what happens is you can go straight away into the anterior chamber, and that produces a very less or a very less shallow wound as well. Things happen in slow motion in a metal knife. I would always suggest for beginners especially, go for a metal knife. Only thing is a metal knife of good quality, and make sure this metal knife was not used for too many cases. Definitely better control is there with the steel keratomes as well. So this is this just to show you that, and just to show you another wound you can see here. Always, as I told you, make the incision tight or the anterior chamber tight, inject viscoelastic, and then if you have it loose, if the anterior chamber loose, the intraocular pressure is very less, then it makes life difficult because the wound can buckle, and you will not be able to create a good internal corneal valve, which is very, very important for the closure of the wound when you hydrate the side port as well. You can see the post-operative day one, after a brown cataract, the wound is pristine. You do not know where the wound is actually. So that is the advantage of these MICS incisions and the incisions which are made with the diamond knife as well. Making the side port entry, try to make a shelving section. Left side port, be careful because these are all in the 6 o'clock or in the inferior zone. The inferior zones are all exposed to atmosphere. Be careful. You have to be very, very watertight in these patients. Make sure that you have a longer tunnel. Also the left side port, that is the left eye side ports are very, very important. More dangerous in the larger side port, especially in the bimanual IA, because you're making two side ports. In the biaxial phaco, also because you're making two ports of about 1.4 or 1.6 millimeter. Extension for IOL incision, use a sharp crescent, keep it in the same plane. See that you don't cut the flap too superficial. You will have a free flap. Make the incision slightly loose, then slightly tight. So closure of the phaco wound is also very important because the intraocular pressure assisted physiological. Hydration of the stromal edges is also possible. If the leak is suspected, better to put a suture. Don't let your ego come in the way. Always put a suture. because it is be safer than sorry. You can see here how I'm doing the stromal hydration, the closure of the wound, going to the side of the incision and checking the intraocular pressure. Checking the intraocular pressure repeatedly. I check it at the 6 o'clock, sub-incisional, at the 12 o'clock. You can see I'm checking with the bud. I'm making sure. Sometimes you can do the fluorescent test or the iodine test, which I'm going to show you as well. Again, is another patient. You can see here how I'm making this incision. This is a 300 micron guard knife, which I told you know exactly where to start with and go up on the cornea, then enter into the anterior chamber, all in a smooth fashion. In one stroke, you can do that as well. Then you create the side port as well. Please understand the left eye side ports are exposed. The right eye side ports are not exposed. They're all in this thing. You can see how I'm doing the stromal hydration. Go to the corners of the incision and then do the stromal hydration. How the anterior chamber deepens and the lens goes back as well. And always test the wound integrity by putting the cotton bud at the 6 o'clock or wherever you're sitting is at 12 o'clock. You can see here, 12 o'clock. I always ask the patient when I'm in topical anesthesia whether they're able to see the light. If they're not able to see the light, it means your intraocular pressure is going beyond the central retinal artery pressure. And that is again very important to lower the pressure by releasing the side port as well. I keep the pressure around 30 millimeters of mercury because I want to make sure that the internal corneal valve is well closed as well. You can see here, just to show you how I'm hydrating the side port and the main port. And then once I'm doing that, I'm putting the apadin. That is the povidone iodine, 5%. Once I put the apadin, you can see there's absolutely no leak through the main port as well as through the side port. And this is an iodine test, or you can do this, the fluorescent test also. Conversion of the Phaco wounds is also very important. Superior scleral wounds can be extended. Clear corneal tunnels should be extended very cautiously. I would suggest that if you're going to convert from the Phaco into a ECC or an SICS because you have lost the rexis or something like that, or you ended up with complication, then I would suggest that you close the corneal wound with the suture and then extend or relocate yourself superiorly at the head end of the patient and open up the conjunctiva and make a scleral tunnel. If large corneal extension, close and reopen superiorly, very, very important. So always go superiorly then inferiorly when you're going to do the corneal extension, and always put multiple sutures to close these wounds and check the wound integrity. Just to show you how you're going to extend a scleral tunnel, you can see here how I'm extending that, the scleral tunnel or incision into the, from a 2.8 or 3 millimeter to about 6 or 7 millimeter incision. What are the complications of the Phaco wound? The incision can be too deep, it can have a UVL exposure, incision is too superficial, tearing of the tunnel roof can occur, wound too long, we can have corneal striae and sometimes wound burn as well, hydration of the cornea, wound too short, you can have iris prolapse and wound leak, too tight, you can have descemet stripping, stromal hydration can also occur because of this. These are the various complications which can occur because of the wound construction, either wound burn or a wound leak or ragged edges as well, and all these are going to be a problem. Just to show you that the main port as well as the two side ports, all the three ports, both the main port as well as the side port, there is a problem of the shallowing of the wound. The wound is very shallow, and that is the reason why the iris is starting to coming out. Especially in a patient with the IFIS syndrome, this can make the life very, very easy. Again, another patient with a shallow wound, you can see that iris has started prolapsing out, and this can make very life very difficult. Ragged long tunnel, you can see here the long tunnel, it's also very ragged as well and can produce a problem. A long tunnel can produce hydration, can make life very difficult for you. There is a patient with the corneal burn. Corneal burn can occur because of the smaller wound, a tight wound, and you're using excess Phaco energy, or you're not giving Phaco without removing the viscose which is there in the anterior chamber, you can have a corneal burn. This corneal burn can be very serious, very difficult to close this corneal burn. Multiple sutures may be required and can produce irregular astigmatism, wound gaping, infection, and even endophthalmitis. So the corneal burns are something which is very, very important. You can see this is a corneal burn. I put an air bubble into the anterior chamber. This is a patient with the multifocal lens. Just keep your ego in the back of your mind, making sure that the patient's safety is much more important. And you can always remove the suture after about 2 weeks or so. And you can see the corneal burn is well sutured now, and the wound is stable, and the wound is quite, and this wound will not leak at all. Once you put a wound burn with the suture, you can see here, this is a wound burn, again a corneal burn, and always making sure that you put a suture there and making sure that this thing is there. Just to show you the wound leak, I'm trying to hydrate. You can see the lens is moving forward. The anterior chamber is still shallow. Okay, if we leave it like that, this patient will have postoperative shallow AC, more importantly, endophthalmitis as well. So I have not left it like that. I can see I put a suture there because I know that this wound is not a very good wound. Once I put a suture, then I try to hydrate the main port as well as the side port, and they can see the anterior chamber deepens well, and the lens goes back into the posterior capsule. You can see here, I'm hydrating both the main port and see, now you can see the anterior chamber is very, very tight. And this is the take home message. The end of the day, or the end of the Phaco emulsification, you have to see this. And before you see this, don't try to remove the speculum. Again, you can see this wound leak. I'm testing with fluorescent. You can see I'm putting a fluorescent dye. I'm putting the fluorescent dye both in the main port as well as the side port. You can see the main port, it is not leaking at all. You can see the side port, you can see it is leaking, which means the side port is not good enough. So what I do is, I do it again. I go and do the stromal hydration again and try to, so you can see here, it is leaking much less, but still it is leaking. I do the stromal hydration again and close the wound. And most important thing is the wound has to be both the main port as well as the side port. How many ever side ports you have created, whether it's I always use the coaxial irrigation aspiration. So I always create one side port, that is the left side port, I always create. But if you're going to do bimanual IEA, you have to make sure the bimanual IEA, the wound architecture is as important as the main incision as well. Plan the architecture within the incision funnel. Make a square incision, as much as a square incision as possible. Use good trapezoid blades, near limbal incision or anterior limbal incision. Look for the vascular bleeding or the ooze at the start of the incision. That is very, very important. Curved incision, arc length is bigger than the chord length, angled at about 30 to 40 degrees. Slightly larger incision better than the tone one or smaller incisions. Incision on the firm eye is very, very important. Always inject viscoelastic or make the main incision first before you put the side port incision. Wound burn, wound gape or wound leak, always identify at the end of the surgery and always apply a suture. Many choices for Phaco wounds are available. Learn all, be consistent with the technique. Analyze the outcomes in the patient series will allow astigmatism control in cataract surgery as well. Thank you very much, J&J and Karan, for the wonderful opportunity. And we can take the questions now. Thank you very much. I'll stop sharing my screen.
Thank you, sir, for that wonderful talk. You know, it was very detailed and it would answer the queries of all the Phaco surgeons, particularly those, you know, who are just starting Phaco. Wound construction remains a problem for them, and this would have solved a lot of their queries. Sir, a couple of questions from the audience as well. And so one question that I would like to ask you is, you had already talked about, am I audible? Am I audible?
Yes, yes.
Yeah. So one question, Mohan sir, I would like to ask you is, you had already showed regarding for clear corneal that you would do creating a groove via a crescent knife and then entering via keratome. So that would be a triplanar incision. So any choice you would have versus a biplanar versus a triplanar incision?
No, I could get the question, Karan, because I was out of, yeah. Can you repeat the question?
Sir, you had showed regarding in your surgery that you had made triplanar incisions using first a crescent knife and then followed by a keratome knife. So what is your choice? When would you go for a biplanar versus a triplanar, and which is better in your opinion?
Yeah, I would suggest that all the beginners go for a triplanar incision. That is, you make a groove, then you make with the crescent knife, and then you enter the anterior chamber, because your wound integrity is much better. Then as with the experience, what happens is you can try and do this in a two-planar, the biplanar incisions. So you know exactly what is the feel of the tissue. Then you know exactly what to do. So initially, I would suggest that you make, just like the scleral tunnel, what you make for the SICS. Similarly, you make a corneal tunnel also with a crescent knife. So exactly, otherwise what happens is, when you try to make the biplanar incision, you have a tendency to, especially when you are not experienced, you have a tendency to enter the anterior chamber prematurely. If you are entering the anterior chamber prematurely, then you will have a shallow wound. And the whole phaco emulsification, the whole process becomes very, very difficult after that. Because iris will start coming out, the anterior chamber will shallow. Post-operatively, it's a real problem. You need to apply suture. Otherwise, if you leave it like that, the wound leak can occur. See, please understand this. When you have a corneal wound, the corneal wound, every time the patient blinks, when the patient blinks, there can be micro leak. The serials will be negative, but there can be micro leak. And whenever the patient becomes micro leak, there can be fluid ingress from the conjunctival sac into the anterior chamber. And that is, I think, one of the most common causes of endophthalmitis, in my opinion.
Sir, consider you had said if a person makes a shallow incision, so we'll move on to this only then. So if a person has made a shallow incision and iris is coming out again and again, would you change your incision, or what steps would you recommend to our beginner surgeons so that they could handle it better?
Yeah, if you feel that the incision is very shallow and you're not able to proceed with the phaco, the iris is coming out, I would suggest that you close the incision with the suture. 1 or 2 sutures, you close the incision and make the incision probably a little more, a few clock hours. Either you go supero temporally, if you're going to be temporal, supero-temporal, or even superiorly you can go that. So to avoid this shallow incision, that is the reason why I'm suggesting to all the beginners, because this talk is mainly for people who are going to start phaco or in the process of starting phaco. So that is the idea of this talk, wherein you make a crescent. If you have a crescent, then you have a better control. If you have a crescent, you can have a tunnel, very nice tunnel into the cornea. And because if you have a sharper instrument going into the cornea, you do not know when it is going to enter. So that is the reason why I'm suggesting that.
So there's a question also from the audience.
Yes.
Starting, as you had said, see, diamond blades are not something that everybody can afford. So most of us are using metal knives, as you had said. So is there some type of keratome or a company or something? I know you won't endorse anybody here, but is there a specific type of keratome you would recommend?
I would recommend Mani blades. I would recommend Mani blades. These are a little costly blades, but you can use it for about, each of these blades, you can use it minimum for about 4 or 5 cases. And the sharp edge is also good. Only thing is sharp edge is only for 1 case you can use that. It's much less costly. It's about 70 rupees or 60 rupees or something like that for each blade. But you can use it only for 1 case. The Mani blades are very good. That's what I'm using that. Or you can go for the Alcon blades also, which is also very, very good. Unfortunately, the J&J are not making blades. Otherwise, I would have endorsed them. Yes.
So you had also showed a pediatric case where you had shown a scleral tunnel.
Yes.
So would you recommend for all surgeons, beginner surgeons, to start via scleral tunnel or via corneal section? Yeah. Question 1. Second question in, if for what cases would you always do a scleral tunnel?
No, all my pediatric cases, I used to do a lot of scleral tunnels, but nowadays I'm doing near limbal. That is going from the anterior limbal, but I always put a suture in pediatric cases. So for the beginners, what we used to do is for the people who are coming for Phaco training, we always used to start them with the scleral tunnel. The simple thing is, scleral tunnel, suppose you want to convert into an ECC or a SICS, is much easier to do the scleral tunnel, much safer as well. So that is the idea of the scleral tunnel. And also they'll get the feel of making a tunnel. So instead of going into a clear corneal incision. So that is the idea. So otherwise nowadays, I think clear corneal incisions are as good as the thing. Only thing is, please understand one thing at the end of the day, that the clear corneal incisions are not as strong as the scleral tunnel. Scleral tunnels are covered by the conjunctiva and they got extra safety. Whereas clear corneal incisions, they are directly exposed to the atmosphere. So many people, in fact, don't even patch the eyes after clear corneal incision. I patch the eye at least for a few hours. So I don't want this exposure of the atmospheric air, because the atmospheric air in our country contains about 85,000 to 90,000 bacteria per cubic millimeter of air. So immediate quantum of exposure, huge quantity of exposure to the corneal wound, sometimes there can be small abrasions. That is the reason why I always patch, because I allow about 5 to 6 hours for the abrasions to heal. So clear corneal incisions, be careful about the clear corneal incisions. Instead of making 180 degree on the right eye, that is exactly temporal. What I do is, in both eyes, I go a little superior temporal. I go a little superior temporal because I want that incision to be covered by the lid. Okay, so that they are not exposed directly to the atmosphere. So this is a message I want to give.
You were just saying about supratemporal incisions. Would you change your incision according to the steep axis, sir?
Yes, sir. Many of the patients have against the rule astigmatism, in the sense that the horizontal meridian is slightly steeper than the vertical meridian. So I go according to the axis. If the axis is much more than that, the more than 1 or 1.25 cylinder, I obviously am going for a toric lens. And whatever the toric lens, the Barrett toric calculator gives me, whatever incision I put. Normally the incisions are 180 degree in a Barrett toric calculator. If we're going to do a toric lens, 180 degree in the right eye and 30 degree in the left eye.
So do you do OCCIs and LRIs?
I have stopped doing LRIs. I'm doing the femto astigmatic keratotomies now for patients who have got 1 to 1.25 cylinder. I'm doing that as well, but I've stopped doing LRIs for their this thing. So anything which is more than 1.25, 1.5 cylinder, I straight away go in for a toric lens.
So what about OCCIs? Do you do for about 0.75 astigmatism? Do you believe in OCCIs?
No, I used to do that before, but I have not found results are very, very effective. Opposite clear corneal incisions. Yeah.
A very important point that sir had said is regarding patching the eyes. And sir, I even patched the eyes for about 2 hours at least for the same reasons, and for another reason that the patient is also more comfortable, then they can take it off and start their drops. So there are a couple of audience questions that I would like you to address. Yeah. Dr. Ranjit Singh Rawat has asked that what are the factors contributing to a DM detachment if it occurs particularly in the main port or a side port, and how would you manage such situations? Would you change your approach? Would you change your incision?
Yeah.
How would you tackle this prediction?
Yeah.
Particularly in different stages of Phaco.
Yes. DM detachment occurring during the main, that is at the site of the main incision, is something which is a very serious problem, which is very difficult to manage, especially during the surgery. So post-operatively, you can manage that, but putting a gas or air or whatever it is. But during the surgery, when you have this thing, how do you avoid the DM detachment? DM detachment can occur in 1 or 2 or 3 stages. Okay, one is when you're using a very blunt keratome. Okay, when you're using a blunt keratome and trying to enter the anterior chamber, then you can produce a DM detachment. That is one possible. Or the wound is very tight. Sometimes you can have a DM detachment. Or during the stromal hydration. Okay, please understand, stromal hydration is another important thing where you can produce a DM detachment. So these are the things. And another thing is always go with the cannula inside the anterior chamber and then inject the viscoelastic. If you're always, many of the beginners, what they do is they keep the cannula at the incision without putting the cannula into the anterior chamber, either the viscoelastic through the side port or the main port. If you are having it only at the incision and trying to inject the viscoelastic, you can produce a DM detachment. During the surgery, if you're going to have DM detachment, what I would suggest is put lot of viscoelastic, that is viscoat and a soft shell technique. Okay, put viscoat that will push the DM towards the stroma. So the very important viscoat, and then put Hyalon underneath. Use low flow parameters, okay, and try to do the phacoemulsification. Now and then you have to keep on injecting viscoat to the side port so that you don't want to aspirate the flap. The flap should not come out because you have to use less vacuum, less aspiration flow rate, slow motion phaco. Keep the phacoemulsification as posteriorly as possible. That is called posterior plane phacoemulsification, because if you have lower parameters, you don't have to bother about the posterior capsule or iris coming into the port. So keep this thing posterior plane phacoemulsification, and then don't try to come out of the eye. We try to, every time you come out of the eye, the DM detachment is going to come out. So always try to inject, ask your assistant, or you can inject yourself, ask your assistant to inject viscoelastic through the side port. And then the soft shell technique is very, very important. So once you identify the DM detachment, you finish off the surgery, and then post-operatively, then you do a anterior segment OCT. Okay, if there's a limbus to limbus corneal edema, there are two things which you have to think of. One is the TAS, okay, in the post-operative period. Another is the DM detachment. DM detachment will be, once you do an AS OCT, you know exactly where the whether the DM detachment is there or not. Then you can inject an air or a gas or whatever you are comfortable with, and make the patient in the prone position for some time, and the DM detachment will settle down. So these are these things. Always don't use a blunt keratome. The blunt keratome, especially in patients who have got Fuchs or cornea gettata, be a little more extra careful, because in these patients the descemet is a little loose, attached to the rest of the stroma. So you have to be a little more careful. Always examine the patient. If the patient has got cornea gettata or Fuchs endothelial dystrophy, these are patients like, I had a patient who had end-to-end detachment during the surgery. During the surgery, I was just all of a sudden getting some reflex, and all of a sudden you will see that reflex on the in the anterior chamber, and that is where then I did all these maneuvers. Post-operatively, we had an end-to-end detachment, and we injected air. The patient became all right, and patient recovered 6/6 vision.
If you would allow me, I'll just add a point, sir.
Yes, sir.
If what I do is, sir, if there is a shallow DMD, particularly in the main port area where I have to introduce my phaco and my phaco is still left, as you had said, I would inject viscoat from the side port to push that DM up, and then I would introduce my phaco tip inside and then turn on the irrigation. So in such a way,
absolutely,
then if you bring it from outside, if the irrigation is on, then it will detach it more. So I go inside and then turn on the irrigation. And another tip I would add is that hydration has to be very gentle in such cases where there's already a DMD. Otherwise, and put air in if you suspect that it is not settled at the end of surgery.
Absolutely. Sometimes you can have small detachments at the incision site, because you're not going with, sometimes you're going with the irrigation inside, and you're not depressing the posterior lip while going. You're going towards the anterior lip with the phaco tip. That itself can produce a DM detachment. So always the end of the surgery, even if the detachment is small, put a small bubble of air. That is good enough to close this DMDs.
Thank you, sir. So there's another question, sir. What are the causes of fixed mouthing of the incision, and how do you avoid it? Any tips for that?
The fish mouthing.
Jyoti Kanade.
Fish mouthing of the incision can be because of the ragged incision. If you have a very ragged incision, then you can have a fish mouthing. Okay, so that is why I'm telling you, you have to, especially when you have a longer incision, it's likely to be ragged. So if you're going to have very poor quality blades, you can have a ragged incisions. Or if you're going to be very clear corneal, too much of into the cornea, you can have a ragged incision. So all these factors can occur, you can produce fish mouthing of the incision. And this is very, very dangerous. You need to put sutures for these incisions. multiple sutures sometimes. It is fish mouthing is similar to the corneal burn. Wound gaping can occur because of that.
So since you're talking about corneal worm, I think you've just spoken on it also very nicely. But the audience has also asked it again. Could you please again elaborate? What are the tips that you would say to avoid the corneal burn?
You see, corneal burns. What are the first of all, you should know what are the reasons, causes for the corneal burn. Number one, if the incision is very tight. If the incision is very tight, for example, you are putting a 2.8 millimeter sleeve into a 2.4 millimeter sleeve. It's like that. Okay. So what I do is always I go inside and make the turn this Phaco tip like this and this, because I want the incision slightly to be bigger than whatever I want. Okay. So if you make it too bigger, that is in the beginning itself, you cannot make it smaller. But if you make it smaller, then you can make it slightly bigger. How do you make it bigger? Not with the keratome, with the Phaco tip itself. Go inside and make lateral movements this way, that way. So 2.8 will actually become 2.85 for you. Okay, or a 2.2 will become 2.25 or something like that. Okay, so that the incision, because the incision is not very tight, and the incision, the fluid will go through the sleeve and allow the cooling of the tip. So the cooling of the tip is one of the important factors. The incision is very tight, the cooling of the tip does not occur, and the heat gets transmitted into the cornea straight away, producing a corneal burn. So that is one. Second thing is, with the incision, if you are using too much of Phaco energy, if you are suppose dealing with a brown or black cataract, a lot of Phaco energy, 100% of the Phaco energy, 100% of the time, then you can have a corneal burn because of excess Phaco energy which is used, and that can also get transmitted to the cornea. Okay, number two. Number three is, as I told you, the viscoat. When you are putting the viscoat there, especially when you're using tips like Ozil, okay, the Ozil does not aspirate like the longitudinal Phaco, like the ellipse or the other one, the regular longitudinal Phaco, like what we're using for the Stellaris and other missions as well. So the Ozil, it takes a longer time for the Ozil to aspirate. The viscoat is a very, very thick. It takes a long time for the viscoat to aspirate from the anterior chamber. So when you're putting viscoat, always aspirate a little amount of viscoat before you give the Phaco power. Okay, before you make the trench, because the viscoat, if you don't aspirate, and before that, if you try to, the viscoat will go and occlude the Phaco tip, and what will happen is the Phaco energy, okay, because there's no fluid coming out of there's no cooling of the tip there, and because of that, the Phaco energy can get transmitted straight away to the cornea. And I have burnt my fingers several times, especially with the Ozil one. We have to be very, very careful. Whatever machine you're using, always aspirate the viscoat, what you're doing, which you're using, because sometimes you use viscoat regularly for especially brown, black cataracts. Make sure that you remove a little amount of viscoat there and then go ahead with the trenching if you want to do the trenching. So this is very, very important. Or otherwise, straight away, if you're going to do a vertical chop technique, straight chop technique, anyway, you're going to use more vacuum, more aspiration flow rate if you're going to use a peristaltic machine, and then go ahead with this thing, and then that will automatically aspirate the viscoat, because viscoat takes a longer time. So that is important. So you can see that once you don't aspirate the viscoat and try to give the Phaco power, right under your eyes, you'll see the cornea becoming white. So this is again very important. These are the factors. So once you avoid these factors, very important, make the incision slightly larger than what? Don't make it too large. If you make it too large, more of incision, the AC will start shallowing. Make it slightly larger. Suppose you are having 2.8 millimeter, don't enter into the anterior chamber too much. Enter slightly, as I showed in the videos, enter 3/4 or almost 4/5 into the anterior chamber. So instead of a 2.8 millimeter keratome, will actually give you a 2.75 millimeter, okay, or a 2.7 millimeter, or 0.1 millimeter less it will give. But once you go inside with the Phaco tip and this thing, then you do give the lateral movements. The lateral movements will actually slightly stretch the incision slightly, and that make the incision a little more bigger than what you can imagine.
Wonderful tip, sir. So there's another question regarding the precautions in wound integrity that you need to take during IL insertion. You already talked about, to avoid, you were not contemplating against, you were saying against the wound assisted, particularly for the beginners. So any tips to maintain this integrity and...
Yeah, please understand one thing. The wound assisted is you are injecting a lens through a very small incision. Okay, the cartridge is not going into the anterior chamber. The cartridge is at the tip, that is the mouth of the incision. Then you are trying to push the IOL through that small incision. So what happens is when the cartridge is trying to contact that, there can be a distortion of the wound. So they have found out that the wound architecture is not very good post-wound docking. That is the docking of this thing. The wound architecture starts gaping as well, and there's a lot of damage to the stroma as well. So the collagen, everything gets altered because of the wound docking. So what I would suggest is make the incision slightly bigger, okay? And for for example, the platinum injector, which is there with the J&J, it goes through beautifully through a 2.2 or a 2.4. I don't use, though I use a 2.2 millimeter, they advocate, I use a 2.4 millimeter. Actually, both when I'm using the Centurion as well as with the J&J, there is the Signature Pro or any other machine for the matter. I go for the 2.4 millimeter incision so that my cartridge goes inside slightly into the anterior chamber, and then I'm able to see. If you're able to get that cartridge inside, then the wound distortion does not occur. And whatever you try to inject through that is the wound assisted implantation, there can be a distortion on the wound and you don't have any control over it. Yeah.
Thank you, sir. Another question is, you had shown in one of your videos and you had mentioned this, like if the incision is quite posterior or a little bit posterior, there can be ballooning of the conjunctiva. Yeah. So when would be the right time to tackle this ballooning and how you should do it? Because it is going to obscure your view, fluid is going to come in the way and you won't be able to see.
One of the worst things is that. One of the worst, because it can be very troublesome. A lot of reflexes can occur on the cornea. There can be pulling of the fluid on the cornea and multiple reflexes, and you will not be able to see. And I would suggest that you do it as early as possible. As early as possible. As soon as you see the ballooning of the conjunctiva, try to make a nick in the conjunctiva near the incision itself. You can make a nick in the conjunctiva and try to drain the fluid. Or you can even open the conjunctiva with the Westcott scissors and try to do it this thing. But don't make it too posterior. Make it always anterior near the incision so that you make sure that the incision is quite open. That is in the sense that a little bigger one, and make sure that it's go all the way up to the sclera. Then only the ballooning will not. Otherwise, you make it partially. The subtenon, that is the tenons, will be there sometimes, and that can produce more of a problem. So the ballooning can extend. So always make sure that you make a full thickness incision on the conjunctiva, cut on the conjunctiva, and then try to drain all the fluid with the cotton bud, and then proceed with the phacoemulsification. My suggestion is do it as early as possible before the things become a little more, because sometimes you can see all of a sudden, all the 360 degree, it will start coming out.
Excellent.
Yes, sir.
Sir, one more question now is that if there's a PCR and you've got a nucleus inside, it's about to dangle down, and you have to convert to an ECC or an SICS. You had touched on it a little bit, but I would like to ask you is, what would be your choice in situations where, first situation where it's about to drop down, whether you would convert to an ECC or an SICS. Second situation, the nucleus, there's a big rent there, the nucleus is still in position, but then would you convert to an ECC or an SICS?
Now, how big is the nucleus? That's very important. Whether it's a full nucleus or a half nucleus or a quarter nucleus.
So you can take each of those scenarios separately.
Yes, sir. If it is a full nucleus, there is a PCR, the lens is starting to sink into the vitreous cavity, then I would suggest that you straight away convert into, close the temporal clear corneal wound, and then extend, open the conjunctiva, do an SICS, do an ECC, and go ahead with the phaco, with the whatever you want, the nucleus delivery. If it's going to be a half nucleus or a quarter nucleus, then we can do what is called IOL scaffold. Okay, IOL scaffold, put a 3-piece lens in this thing and bring the lens up. Make sure that you do a fairly good anterior vitrectomy, and because we don't want the vitreous to come into this thing, and make sure that the entire nucleus is brought up into the anterior chamber, and then do a good anterior vitrectomy. Use a tricot, do good anterior vitrectomy, and then put the lens in the pupillary area. On the surface of the iris also you can put it, and then try to remove this nucleus with the phacoemulsification, making sure that the good amount of viscoelastic is there. Nice taking like viscoelastic. I don't have any financial interest on viscoat, but all the Indian companies are also making something similar to viscoat, and you can use that as well. Protection of the corneal endothelium is very, very important. Once you do that, then you can have an anterior chamber maintainer. If you have remaining epinucleus or cortex, you can go underneath that lens and try to always remove the vitreous first and then remove the cortex. You can do a bimanual technique, or you can just have an anterior chamber maintainer and go through the right side port and try to see. Once you do that, you can put the lens in the sulcus and then capture it in the capsular axis if your capsular axis is intact. Always capture this lens, don't leave it in the sulcus. If your capsular axis is intact, leave it in the sink. And always, when you have a PCR, please put sutures for both the main ports and side ports. Why I would tell you? Because you'll think that the wound is tight, but the wound leak. The wound leak occurs even if the main wound leak is there. If the vitreous loss is there, the incidence of endophthalmitis goes up by as high as 5 times. Please understand this. So whenever I have a PCR and I'm extending both the side, we extend even if we don't extend the main incision of the side port incisions, because I create a right side port for the bimanual incision, bimanual irrigation or the vitrectomy also, I always put sutures for both the main as well as for the side ports as well. So this is a take-home message I want to give you. So if it's full nucleus, convert, shift and convert. If it is a half nucleus, whatever you are comfortable. If you still want to convert into an ECC, but again, I would suggest that you shift from the temporal to the superior and make a scleral incision or a limbal incision.
Thank you, sir. We've covered a lot of points about the main incision. Now coming to the side port that you were talking about.
Yes.
Now, how many clock hours would you say that they should be distance away from the main port? Point number one. Second of all, is that there are various types of side ports that are available in the market. The long one, the short one.
Yes.
What would you recommend, and any tips on constructing it as well?
I use the 15-degree, the side port knife. You can use a myringotomy knife also. But what is important is to make the side port also self-sealing, and very important is to have you don't have to have a very long side port like the main port. Probably, for example, 1 millimeter by 1 millimeter, or 1.5 millimeter, 1.5 millimeter. What I have on the femto catalyst machine is a 1.5 into 1.5 millimeter. But what I do manually is about 1 millimeter by 1 millimeter into the cornea. So side port incisions are also very important. Calibrated side port incisions, I was talking about Rohit Om Prakash, fantastic innovation. It's very, very also very important when he calibrates the side port incisions also. Many of us don't give importance to the side port incisions, especially the left eye side port, I told you, because it is exposed to the 6 o'clock meridian. You have to be very careful to expose straight away to the atmosphere. And if it leaks, you are in trouble, because that can produce endophthalmitis as well. Infection, recurrent inflammation, and all these are causes of because of micro leaks which are there because of the side ports there. So again, very important to have a good side port. I would suggest a routine 15-degree, which is available. Don't the myricotomy knife can also be used if you're not comfortable with the 15-degree.
Sir, how many clock hours would you suggest it should be?
Clock hours. Yes, if you're going to do the chopping techniques, okay, whatever you're comfortable, whatever techniques. We're going to talk about nucleus management a couple of modules later about the nucleus management. If you're going to talk about this thing, you're doing the chopping, divide and conquer. Many beginners do the divide and conquer, the 4-quadrant technique or the stop and chop, whatever it is. Then I make the side port 90-degree. Okay, suppose the main port is at the 180-degree. I'll make the side port around 90-degree. That is at 12 o'clock. So this is this is at 9 o'clock, this is at 12 o'clock. So that's what I would say. So in a divide and conquer. But if you are going to do the chopping techniques, the stop and chop or the direct chop, or the vertical chop or the horizontal chop, I would say, then you keep the side port slightly closer. That is, the main port is 180 degree. Then you keep the side port maybe around 70 or 60 degree or something like that. So about 2 to 3 clock hours from the 2 clock hours from the main port, because it'll be easier for you to chop. Because if you're going to have it further down, it's easier for you to divide and do the divide and conquer technique. For you to chop technique, you need to be as closer to the main incision as possible. So that is the whatever you are comfortable, you can do that. But normally I would suggest anywhere between 70 to 90 degrees from the main incision.
One tip I'd like to add, if sir allows me, is that when beginners, if you're making the side port, particularly the left side port, is don't make the full entry, because then the wound leak and you'll have problems. So I would recommend to do your chopping and then extend the incision later on when you're trying to do a bimanual IA or something. So would you do the same for the for the beginners?
Because I'm not using bimanual IA even for my trainees. Everybody they're using only coaxial IA. So what I would suggest is, because the left side port has to be done. Okay, you are a right-handed surgeon, so left side port, if the left eye, the left side port has to be inferior. So how do you expect them to make it in the superior?
No, sir. I am saying don't enter with the side port completely. Don't make a big incision of the side port. Make a smaller incision where only your dialer or your chopper enters.
Yes,
and
sir.
Later extended is required.
Absolutely. That is, when you are using bimanual IA, you need a little bigger side ports. Please understand. Bimanual IA, you need about 1.5 millimeter minimum of a side port. Okay. Whereas if I'm using only a chopper, I use only less than 1 millimeter. My chopper is very thin actually. My Mohan Rajan chopper is quite thin. Can go through even a 0.75 millimeter side port. So it's very easy to go. It's long and sharp, but it's also a little thin as well. So that is the advantage of using a coaxial irrigation aspiration, because you don't open up the side port as much as a bimanual IA. So bimanual IA, you have to be a little careful. You have to be doubly sure, 200%, not 100%, 200% sure that your ports are well hydrated. Look for the fluorescent test, and if there is any chance, keep hydrating, or you can always apply a suture there.
Wonderful tip, sir. Just last question for today before we wrap it up from the audience. Pediatric cataract does have its challenges, from the scleral rigidity to the rhexis, where it just runs away. So Dr. Meenakshi Wadhwani has asked, after how many cases of adult cataract pediatric you should start, and is it important to do Phaco in pediatric cases in the beginning?
Absolutely, Phaco only. Phaco aspiration. It's not going to be Phaco, full Phaco emulsification. It's only or you can just do a bimanual or coaxial irrigation. Many of the cases you just do a hydro, everything comes off. It walks out like that. But the most important thing is the wound construction in pediatric cataracts and the rhexis, both the anterior rhexis and the posterior rhexis. More importantly, the anterior rhexis is very tough, because it's so elastic, it starts running away to the periphery. And what if you aim at about 3 millimeter or 4 millimeter, you'll end up in a 6 millimeter. So that is a problem of the pediatric cataract. My suggestion is, unless you are keeping on doing pediatric cataracts, it's not a question of, please understand this very, very clearly. The pediatric eye is not a miniature adult eye. Okay, it's a totally different ballgame. Totally different ballgame, because everything is different in a pediatric eye. The scleral rigidity is there, different. The tissue, the touch of the tissue is different. The capsulorhexis is different. The nature of the capsule is different. The posterior capsule is different. Of course, the nucleus and other things is not a very major issue, but all other factors come into play. The positive vitreous pressure is there in pediatric eyes. So all these things are a very, very major issue. My suggestion is, unless you have a formal training for a pediatric cataract with a pediatric ophthalmology fellowship, don't even dare to do this pediatric cataract. That is my take-home message for you guys. Yeah.
Thank you, sir.
If you think that adult Phaco, I'm expert in adult Phaco, I've done about 10,000 and 20,000 adult Phaco, I can do pediatric cataract. the pediatric cataract is going to be a real, what you call, test of this thing, because it's going to be a different thing. So unless you see or watch veterans of pediatric cataracts doing it or assess them, then you have a feel of it. Then you, because the tissue itself is totally different.
Excellent points by sir. And another thing is, in pediatric cataract, it's not just the rhexis that you have to worry about. You have to do particularly for the younger ones, you have to be good in vitrectomy and do a primary posterior capsulotomy as well. And EUA at the same time, you have to evaluate the retina. There are a lot of things associated with pediatric cataracts. So coming to this, excellent talk by Mohan Rajan sir. We come to the end of today's session. And I hope we were able to take most of your questions, but because of the paucity of time, I think, but still, sir has covered almost everything that there is to do about wound construction in such a detailed and a beautiful manner. I really hope that all of your doubts have been cleared. So thank you, J&J, Jaswinder, Nazmul, for this opportunity to me. And I'm also extremely grateful to Mohan sir, because I was able to moderate a session by the legend, session given by the legend himself. Thank you so much.
Thank you, Karan. Thank you, J&J. Thank you, Jaswinder, for the wonderful opportunity. I think it's been a great experience for all of us. And we'll meet again next Saturday, 3 p.m. for the third module.
So the next session is on CCC and hydro procedures.
That's right.
Saturday, 3 to 4 p.m.
Thanks, Karan.
Thank you, sir.
Bye. Jaswinder, is he around?